Hi, and welcome this morning to another Conversations about CVI with Dr. Cathy Williams. Hello, Cathy.
Hello, hello.
And how are you?
I'm well, thank you. I'm well. How are you?
Good, good, good. Today, I always like to start with a little bit about the weather because we're British after all.
Yeah.
And it's a grey, drab, drizzly, cold. And what's it like where you are?
Grey, bit kind of muggy, not cold, medium, reasonable temperature, but a bit muggy, a bit humid.
All right, that must be the difference between where we are, because you're down south, aren't you?
We're way down south compared to you, southwest.
Yeah,
Yeah.
yeah, absolutely. Good, good, good. All right, good. So I know you very well, Cathy, of course, but other people's may not. So would you like to introduce yourself? Who are you, Cathy, and what do you do?
Hello. Yeah, my name's Cathy Williams, and I'm a paediatric ophthalmologist, academic paediatric ophthalmologist, and I've had a long-term interest in visual development, both normal and abnormal. And so I trained in London and did various jobs, then came down to the southwest a lot of years ago, and have been here ever since. And for most of my career, I've spent some of the time, say half and half, clinical or research. And so with this interest in visual development, I did my PhD as part of a very big epidemiology study in Bristol, birth cohort study. And that gave me a bit of training in sort of epidemiology and health services research. And then I gravitated more in research and clinical to like special needs and different times when visual development might not go as planned. And that obviously led me to CVI. And I learned a lot by reading people who I'm sure we'll talk about, and try to build my service and research based on their learning, and then added it ourselves.
Yeah, because I was going to ask about your interest in CVI. Is that a fairly gradual thing? I mean, do you see as a pediatric ophthalmologist more and more children with CVI? Is this what you're experiencing? And as apart from the research side of things, that's coming on a little bit as well, I think. I mean, are you seeing a lot more?
Well, I think as I've developed an interest in it, once you start looking, there is a lot of it about. Sometimes after a day in clinic, I feel like the entire world is populated with children who've got different degrees of brain-related vision problems. And yes, probably get a disproportionate view. So I see a great deal, yes, but I think people seek me out like now because they know that we have an interest in Bristol, and we try to help and look for that. But yes, I think once you start looking, there is a lot of it about.
All right, good, good. And I think that's a very nice link into my next question, I think, Cathy, is once you start looking, and I believe that you've just done a huge Let's Start Looking project.
Well, yes, I've been very lucky. Basically, it all started when I started as a consultant, as a paediatric ophthalmologist. There were two very key things that stuck in my mind. One was a talk from Gordon Dutton, who you will know, listeners will know, gives wonderful talks explaining about CVI and the different manifestations. And another was a paper by a group from Great Ormond Street about eye movements and how there are lots of different types of eye movements and they can tell you lots of different things. And the key thing was, rather than researching very deeply into just one thing, if in any one child you can get a little bit of information about a lot of different eye movements and aspects of vision, you build up a good picture. So I thought, well, that all sounds very sensible. And we tried to set up a clinic where we would look at lots of different aspects of vision, including those that Gordon talked about, particularly the processing, but also including eye movements and acuity, to build up a picture of children. And I started seeing a lot of children that had, once you start looking in this way, a lot of problems. And after a while, the question arose, well, out there in the real world, how many are there? You know, it's a very selected population, the patients who end up in my clinic. So I applied to our national funding body for fellowship to try and do some research on this, and very fortunately NIHR, they're called, big thanks, they awarded me the funding.
Yeah. Always thank the funder. Yeah.
Always, yeah, and I've it's on the slide later. Yes, so shall I bring up a I've
Yeah,
got one or
yeah,
two slides
I'd
to
be
try and
really interested
explain
to hear about this. Yes, please.
what they've
Great.
funded, because we're still doing it. We're nearing the end, but now I've got to share the screen. Hang on. Where's it? There, share screen. And
It's
then make it
coming.
big.
There we are. Good.
So this is just to remind me to say that as I said, I'd heard Gordon speak, and also other experts I'd visited or heard, like Maggie Woodhouse and Elisa Fazi. We set up this functional vision clinic and found lots of children who had abnormal signs. I should explain that as a doctor, a key part of our training is to find out about symptoms, so what the patient complains of, and signs. That's what you can observe when you examine them. And it wasn't just that there were lots of symptoms, the kinds of things Gordon had explained that you should ask about and can be very informative, but there were lots of abnormal findings when you examined them as well. But I realized that when I wrote reports, I wrote them as simply as I thought I could, but other professionals didn't really understand, so we had to find some way of explaining that better. And even within ophthalmology, and I think this is something, some people have had quite negative experiences of ophthalmology when they're trying to get help for children with CVI. It's not well understood, and a very senior orthoptist sort of teased me about what she called the dark art of diagnosing CVI, because it's not well understood what within ophthalmology, at least it wasn't then. So I sort of put all this together, plus what lots of families had told me, and lots of learning from other people, that there are all these brain-related vision problems which can be lumped together as cerebral visual impairments, but different people have different emphases on, as you will know, what they include in CVI. But we don't really have widely understood guidelines about how to pick them up and how to help them. It's terribly important. Families tell you how important it is, and you know, and little thing, all children differ, but if they've got vision problems that aren't addressed, it can really hinder lots of life. Just get rid of this tag. So we wanted to know how to help, to try and communicate better with other professionals, with teachers and with families. But the important thing was to start to find out how many of these children are out there, as I said. So what we've just completed is a prevalence study where we went to 12 primary schools, 11 of which were mainstream and one was a special school, and did a sort of systematic survey, starting with questionnaires to find who was at risk and information from the school. And then we examined hundreds of the children using standard pediatric ophthalmology methods, like looking at their eye movements, testing their vision, but with a view to finding evidence of brain-related problems, or CVI, whether or not it was known about. And the results of that, I'd love to go through all in detail, but it's with a journal at the moment, as you'll know, so it may change a bit in the review process. I can't quite go into great detail yet, but it was very interesting, and I hope will be very useful. Shall I?
Yeah. Oh, absolutely. I'm dying to know.
Well, yes, it was very helpful. What I'm trying to do is explain it very kind of descriptively, so people can think, oh yes, well, I think that's CVI, but I'm not so sure that that's CVI, but people can take from it what they find useful. But I was surprised there were more children than I had anticipated, but in general it was what you might call the usual suspects. It was children whom one might expect might have problems, born prematurely or struggling at school, and sure enough there were vision problems that we found. And of course I fed this all back to the schools.
Did you so you used just, I'm going to ask a little bit, just to backtrack a little bit around the method there. So you went into these schools and you used your standard ophthalmology assessment tests and a little bit of obviously the questionnaires there. And you obviously, and you looked at eye movements, you said, as well, and all of that correlated into what would be then deemed to be a diagnosis of CVI.
Well, again, people differ with that.
Yeah.
So, and this was a one-off snapshot by people. Mum's not there, so I would be cautious about saying this or that child on the basis of one snapshot. But again, I was surprised. There were some children we've found who clearly had got lots of brain-related vision problems. They couldn't move their eyes properly. They showed clear evidence of crowding. For instance, they had much better acuity for single letters than for a line of letters. They might have a field defect, or they might have some nystagmus where the eyes wobble. And so, and they might clearly have difficulty say finding an image in a crowded scene, that evidence of processing problems. So I would say there was a strong suspicion, even just seeing that child on the page, never having met them, that in fact they had some CVIs, because they have shown us in this snapshot, and we might know that they were born prematurely or they had other problems. So I think you would always want to tie in with what parents, other clinicians, teachers, what the medical history is before labelling anybody as having anything. But it was quite clear that some children showed a lot of vision problems that relate to their brain, even just on a one-off snapshot.
Right,
so
right.
I would call that. I would call that CVIs.
Yeah, the CVIs. And just to be clear, it was just a one-off snapshot. You didn't do a variety of assessments in different environments. It was just
No. It was the same for everybody based on our functional vision clinic. So again, there'll always be occasions where a child is perfectly capable really just doesn't feel like doing it, and it's lunchtime. You get a false impression that way. It was a familiar environment for the children. It was their school, but it was an unfamiliar tester. So for most children, it would be a slightly unusual event, whereas we know many children and adults, in fact, can manage brilliantly in familiar environments with quite profound visual difficulties. But if you put them in an unfamiliar environment, it's much harder for them. So this was a familiar environment with an unfamiliar tester, but it was just a one-off, and you wouldn't normally in real life do that, but it did still, at least you wouldn't stop at that. But it gave very useful information about a lot of children who otherwise wouldn't have had their vision tested.
I'm going to have to ask in a question. Do you have a rough prevalence rate? Are you able to say? If you can't say, then that's fine, because it's empirical.
It all depends on how you define it, and I'm quite keen that. So no, I can't yet. But it's not negligible, but it's not everybody.
All right. Okay. Good.
And every school and every class, every school and every teacher would need to know about this on the basis of our findings, particularly amongst children who are struggling with their learning. As you might expect, children with educational special needs or a known developmental problem, we found easily a third to a half of those children, really? Okay. As other people have found, have got evidence of brain-related vision problems, just fitting in with what lots of other people have said.
What so I've been looking at the data that we're collecting through Vincip and with Cathy Spower. And I'm giving a talk later on this week. I have to give talks as well. It's odd that I'm forcing other people, and people are doing the same to me. Looking at the relationship really between social deprivation and CVI, and I'm really finding quite a significant effect of there is more CVI in areas of greater social deprivation than there is in the more affluent areas. Did you capture any of that kind of data?
Not in our school study, because it was quite small and we weren't really designed to look at that. But in a much bigger study, with the birth cohort, I did a study years ago with Gordon, looking at an amended version of his questions applied to 7,000 children in this birth cohort. And what came out of that is that some of the key predictors of CVIs, like prematurity, are more common in areas of deprivation, and other people have reported that as well. And I think there's a kind of double whammy for how socioeconomic status affects children with CVI, whilst to some extent it can happen in all groups, not just the deprived, but you could be born with, hypoxic problems at birth or cerebral palsy in all SES categories. But the more affluent people can not buy their way out, but are more likely to be able to find help and support for children than less affluent or aware groups. And so children, may be more likely to get CVI if they're born into deprived environment and poor maternal nutrition during pregnancy and all that sort of stuff, and B, they're less likely to get help to kind of support them as they grow, again, in a deprived climate.
Yeah, and it's really interesting because we've looked at, I mean, I think that issue about maternal health is really important, in terms of, diet, smoking, drug use and things like that. I think that's really important. But we've also looked at the difference between genetic factors of children who were born with CVI and non-genetic factors. And those non-genetic factors, it's just really, to me, it screams it's a public health issue. It's
absolutely, yeah,
huge. It's like, it seems to me that with the genetic factors, there doesn't seem to be that strong of a correlation, if any. Our data set's small. It's about 500-600 with CVI, but it's not massive, So the the stats and the power isn't that strong for the genetic, but for the non-genetic, it looks, it's clear. It's clear, especially in the very lower ends. And Scotland has a system called SIMD that really divides it up very clearly and very well. And you can see just the poor affluent areas. It's just, oh my goodness me. And it's a huge public health concern. So I think your research and your work will really add to that argument.
Well, what we're trying to do, like I said, I'm not an epidemiologist, but I know people who are, and we're all very aware now of the importance of epidemiology, is to add that to the general conversations about CVI and look within whole populations at children who may never get to your clinic, who don't find it easy to access healthcare and who may be most at risk of these problems, and understanding how to get to them, but also what, just as you say, the public health measures we might take to prevent CVIs, or at least to identify them and support them early on to stop the repercussions later in life. It's really important.
Yeah, and it's, I just can't see. Well, it's the investment, isn't it? I think it's the investment in poverty that governments really need to seriously look at. Just to reduce that burden of costs for later on, for when the children are in school, they're transitioning into work, to further education and college. It's huge, and it's just, I just try so much to get that public message, and I think your research is so important. So it's in peer review at the moment.
Yes, well, that's the prevalence.
With my journal, it will take ages. The demand is huge. So
believe me, it'll come to you if it gets turned down. Just what you said about the cost and societal, as well as the personal individual cost. If I can bring up the slide again, we are in the middle of another study now that the prevalence study was sort of helping with.
Right.
Here we go. This feasibility study for a randomized trial. So as you will know, and people will understand, money is tight, and money will be even more tight after we come out of this pandemic. And so people have to use evidence to decide on the best way to spend all of our taxes on improving health. And if there's good evidence, like for a glaucoma drug or something, that drug A is better than drug B, that's what gets funded. And we don't yet have really good evidence on a sort of population level of how to get better outcomes for children with maybe the same expenditure or even less expenditure or more expenditure if we address cerebral visual impairment. And so what we're trying to do is a trial to see what the costs and effects are of identifying or empowering schools to identify and support cerebral visual impairment with the help of the health services. So we were in the middle of this. I think. Just we've recruited the schools. Oh, I can't move it forward. Never mind. We've recruited the schools, and this study was going well, but it's obviously paused. And we will get back to it when we can. But to try and produce exactly this kind of evidence, because to help children, it's very good to know how to help them on an individual level, but we also want to know how to build systems so that there are safety nets for them, and so that it's not difficult for teachers, but it's part of their day job. They understand how to help, and that it will help them do their job better if they understand about vision problems and that sort of thing, and to understand the costs and the benefits of that.
Yeah, and many things are terrible about the current pandemic, and I guess, you know, getting back into schools, that's not going to happen. Will it happen this year, do you think? Have you had any contact?
Okay, no, it's like on the news, like for you and everybody else, it's probably piecemeal. Different schools, I mean, a lot of children are still going to school, key workers children and vulnerable children, but everybody back at school, at least for some of the time, maybe in the autumn, hopefully, but with some form of distancing, so they may be not in school all the time. Who knows?
Yeah. You know, and you know, we're just talking about your research here. The amount of research that must just have been put on hold must be incredible. So your second study, your impact study there, I see, you're using the ICF, which is great. You know, the International Classification of Functioning. So it must be me, you, and a few other people I know who use this, and it's great to see.
I love the ICF. Myself and one of my team, Anna, we went to the course in Switzerland, and this is quite the beginning of my fellowship, all over the ICF. Loved it. It's quite a big deal to turn it into clinical practice. I don't know about you, but I haven't managed to do that yet. And in fact, our impact study morphed into what's called a core outcome set, where you work with all the stakeholders, so the families, affected children and professionals, to work out what the different outcomes or domains of life are that are important to all those different people, and kind of produce a list really of these different outcomes that should be included in or addressed in research. And I want to map that to the ICF because I think it's such a brilliant thing. But as I have now learned, there are the ICF doesn't include what they call personal factors, things like IQ or personality, quality of life, whereas other taxonomies, you might call them, ways of mapping, do. So we're going to try and do both. But the important thing was we worked with lots of families. We were really grateful to the families and professionals who took part in this process, and we've ended up with a kind of core list of important things. It's pretty wide-ranging, as you might imagine, but a core list of things that they all felt were really important, and we will try to address that in our study, and that again hopefully will be under review very shortly.
Right, great. Yeah, I mean, I've used it for a while now, the ICF, and you know, and I just can't, you know, I look at all the research papers and see how many, probably out of maybe 100 that come into the British Journal, I would expect to see probably 2% uses the ICF. Yeah. It's like, you know, and you can see the other instruments being used, and you go, oh, if you just had used the ICF, it would have been.
I do. I do agree. I think it's fantastic, and it's such a brilliant tool for translating observations and functional tests into practical goals. The use for rehabilitation and for communicating and tying in what somebody's real problems in day-to-day life are, what they want to do, with how you might try to help them. I love it, but it's quite a big deal. So many people are involved. You can't just use it on your own. I mean, do you find all your colleagues are?
Yeah. I mean, it has to be a huge team approach. I mean, it's not that easy either, which I think people probably look at it and go, oh yeah, and then once you get into it, it's like, oh, goodness me, this is quite complicated, and you need, you know, it's a collaborative approach. But and that's good. You know, it forces that collaborative approach, you know,
Yeah.
in order to answer those questions. You know, it's an enabler rather than as a, oh yeah, I need to ask these people in these teams. And, you know, it enables you to have those conversations to collect that data. We should start a CVI and CVI ICF WhatsApp group kind of thing.
Oh, great idea. Yeah.
Yeah.
I would be really happy to help develop something that was easy to use and accessible, and use that tool to try and translate all these different observations we all make, whether it's talking to somebody or testing them, into, you know, an ICF format to guide helping them.
Well, got something there, isn't it? It's amazing.
Yeah.
Yeah. I'm going to really seriously think about that and take you up on that. I'll email you later about that, Cathy.
Yeah, do. It's a great idea.
And I guess the other thing, of course, is some of the work that I've just started to get into a little bit more now is, trying to find the right quality of life measure. Oh, you know, I'm I'm inundated with quality of life questionnaires at the moment, and trying to work out, I guess there's different ones. Do I want health related? Do I want this or that? You know, for kids with CVI, and that's an issue. So I'll be interested in looking at what instruments you've used for your quality of life. You know.
Yes, well, we in the current study we're using the PED scroll, but in the prevalent study, it's not quite quality of life, but it related. We used a very, very standard questionnaire called the Strengths and Difficulties questionnaire.
Oh yeah, we know that one. Yeah.
Buckets of research on it, and there is this sub part of it called the Impact Supplement. It's just like 5 questions, which basically says, does the child have problems? Does it bother them? And in what domains are the problems? And I don't think it's giving away too much, although it's still under review. And in fact, I want to do a separate paper on this. That was really informative, just those few questions. Not even saying to them, is it to do with their vision or their health, but basically, does this child struggle in some aspects, was very important, because that was a real predictor of,
right, okay.
You know, there may be other reasons. It may not be vision, there may be other reasons, but that was quite an important thing to ask, and was quite simple. It didn't require the parent to think, is it vision, is it their leg, is it their this, that, or the other. It's just, do they struggle? So that's quite closely related to quality of life in a child. It'd be interesting to look at that more formally, but I thought...
Yeah, it's funny. I just examined a thesis yesterday that used the Strength and Behaviour questionnaire, and is very good in conjunction with a whole range of assessments. So yeah, it's something like that. I've come down to using the PEDS-QUAL as well. So that I was hoping you were going to say that, because that's the one I've used. That's right. You know, one academic research into another. Which have you used? And so I've used that. But I've recently, I think, due to the thesis, just come along and looked at the Strength of Behaviours questionnaire, and I've gone, okay, I might need to examine this in a little bit more detail there, and use it obviously in conjunction with other tools and things like that. So it's really something that's coming along, and apparently it's really easy to use and to measure.
Yes, it's very. It obviously, like everything has its limits, but there's parent version, teacher version, child self-report version. They don't all agree, because they shouldn't, because it's different people's perspectives. Right. But the fact it's been so widely used, and there's guidance on whether you're using it in a community sample where most people are basically okay, or a clinic sample where there's a high prevalence of problems. And it was another researcher who explained about the impact supplement, because it's so short. That's very helpful. If you don't give people a long questionnaire, just ask them a few key questions, you know.
Yeah.
That can be very helpful. They can just answer quickly and directly with their gut feeling, and that's often very useful.
All right, good. And you obviously then you just factor load and see how important those questions are. Good. So I think my next question would be along the lines of, as a pediatric ophthalmologist, working in collaborative groups and within schools, and looking what you know that I don't know from your study, because you got all the data. Just give me it, Cathy. Just give me
possibly any day now.
Any day now is what kind of advice or support or systems advice or structure, I don't know, would you give to teachers, you know, teachers first and maybe parents and things like that? Because I think, you know, any help, any advice, you know, let's share it, let's disseminate it.
Well, I think just as lots of people have said, that for any child that's struggling, whether with their learning or with their socializing or whatever, or a child where you know clearly they're likely to have problems because they had a ghastly episode at birth, whatever, a proper vision check where they must be checked for glasses, and then basically, just like I think has been discussed in some other talks, check that they can see what their visual acuity is, whether they've got field loss. It's really important to do a proper vision check of the basic important things, and for teachers to be aware, and we're going to try as part of the current research to produce some materials to try and help teachers add to their toolkit simple strategies to try. You don't necessarily have to wait for a formal diagnosis. Just try making stuff bigger. Just try simple thing. And if on an empirical basis it helps, A, you've helped the child, and B, it gives you a bit of a tip. Maybe this is part of the problem. So I think to try and think vision, it's not just reading down the chart. There might be other things like field loss, there might be processing, and to have a try at addressing those. Teachers now have to, we've learned this from the schools, and you probably know very well anyway, they have to demonstrate what interventions they've tried for Ofqual and so on to help a child learn. Well, if we can give them kind of vision-based interventions to try, and if it helps, you've benefited that child, but you've also moved forward in your thinking about the child, and maybe you think, yeah, let's get some more professional advice on this because we've got a clue that vision is an important player here. So that's what I would say. Get their glasses checked and get to, and my personal view is that all children who are being considered safe for a statement need something like our functional vision check, something like a multi-faceted vision check to see if they've got proper field, eye movement, acuity as part of that process before they get an HCP or whatever, because it's so important.
Yeah, I mean, I totally agree, you know, and the first thing, you know, we teach our QTVIs, and then to teach the mainstream schools and things like that is make sure you've just done the stage one, we call it vision check, right? Ignore all the stuff about CVI. We need to make sure that let's get this baseline measured done. And actually, I go one further than that, Cathy. I say, let's get the hearing checked as well. Let's get a full, you know, audiogram on this as well. You know, let's just make sure the children can see what they can see and what they can hear, you know, and then
they so often coincide. That's again part of the secret paper. I can't talk about it. There's a lot of overlap between what you might call more normal squint, amblyopia, glasses, and processing problems. And then I increasingly find it hard to separate, having read more and talked to psychologists and teachers. For instance, you use your eye movements to do visual search. Visual search might be a sort of processing type thing, finding something in a crowd, you have to use visual search. But if you've got poor convergence or poor eye movements, or you can't accommodate, you'll also have problems with that. So they're all kind of linked. And so getting all of these things checked if you're struggling is really, really important. I completely agree.
Yeah, and it's so important. So that's that, and I guess, you know, populations in special schools, and you've gone into that population special schools. Now, my view is, so I mean, I think all kids should be assessed. Right? Every child should have a full. And Gordon goes, well, that's perhaps not cost effective, and I go, yeah. You know, I sort of agree with Gordon, really, but you know, but in special schools, I think every child in a special school, you know.
Completely. Like I said, and if you made it part of getting an EHCP, which in order to get to a special school you have to have, that's 3 or 4% of the population. That's doable. And it would be lovely if it was a 3-day multidisciplinary residential assessment, but that's not going to happen. That's far too much resource. but a well validated, age appropriate hour with a gap if somebody needs to have a break and go through, assessment. You can learn a lot in that, similar to what we did in the schools. And I do think that's practicable, but still we have to see what the evidence shows. But as a starter, that's where I think
and that's why I wanted you on, Cathy. I want you to get that evidence out, so then we can go and so obviously within Scotland our education system's devolved, and in England is different, and Wales is different, and Northern Ireland, and so really we can go, here's the evidence, let's now start assessing every child in every special school. Let's do this, and then we can start to really build and get these children learning. At the moment there are children we don't know what they can see, and it's just like, it drives me insane. So it's really quite important that we start to do that now, and we have those baseline measures and things like that. And I think, like you say, it's doable. It's entirely doable.
So, I think so. You just have to see the benefits. Like I know Catherine Saunders did a lovely paper looking at special schools, I think in Northern Ireland, and other people. Maggie's done
one. Yeah.
Even in my own clinic, it sounds very silly, but we had a child come with a diagnosis of dyslexia, and did the vision test, and I asked the orthoptist to check their accommodation, which was poor. So we put up +2s, and this poor child's mum cried because he promptly read fluently a paragraph on the page, and there'd been years of being told that he had a reading problem and he struggled and so on. So these basic things are so important to check, and you save the teacher's time if you can make the world visible for the child, whether it's glasses or spacing out or putting it on the left or whatever it is. The teachers can then say, oh, fine, you can get on with it now. So it may be cost effective that way.
Yeah. So
I've lost.
So I need to write to the editors of the journals that you've you sent them off. I need to hurry it up, get these published, unless I'm one of them, of course.
No. Well, I don't know. No, hopefully, one aspect of this pandemic thing is hopefully we can catch up with our writing and just get this all out there to add to all the lovely stuff that other people have done to try and get this bigger sort of public health approach in as well.
Yeah, and I think that's the issue. I think it's been quite interesting from a psychologist education position, is trying to get that message with our medical colleagues such as yourself and Gordon and Andrew and Vincent team into that public health domain arena. It's really, I think it's starting to take note, but I guess like I say, we need the evidence, right? And it's all evidence related, and so hence why I'm just holding on.
It's not going to change the world that much, is it?
But I'll make it so. Yeah, so it's good. Yeah. So what are your plans in the next near medium future then, Cathy?
Well, hopefully we can get back to finishing this feasibility study of the randomized trial, and if that looks promising, it's quite small scale because with something like this trial we're trying to do, there's quite a lot involved, and to do it big enough that you get the answer that means you could change national policy would require a huge investment. So you run it on a small scale first, which is what we're trying to do. But if the results of the small scale thing look promising, I'd want to write a grant for the big thing and hopefully try to really get some rock solid evidence that way. So that's over the next few years. Plus, in my clinical practice, it's been very good to learn so much from other people, and particularly some of the Italian groups. There's this nice tool of the vision sort of, I can't remember what it's called now, but similar to the GMFCS for motor abilities, there's a vision-based one that's very useful for CVI and the ICF, like you said, to continue trying to improve our service and to kind of share it out amongst the profession. So it's not just a special thing that you get if you live near Gordon Dutton or Richard Bowman or me, but that everybody, it's a normal part of paediatric ophthalmology.
Well said, Cathy. And it really is interesting now. I think possibly around 10 years ago, maybe a bit longer. It was, it was Gordon and a bunch of people, yourselves, Maggie, and a few other things. But now we've got excellent work from the States, from Italy, from India, from Australia, from almost everywhere around the world, that are really begun to look at CVI and take CVI seriously, and get that research there. And it's great that we're all sort of coming together, I think.
Yes. Yeah.
We're all, we're all from disparate worlds and fields, pediatric ophthalmology, psychology, education, and we're all sort of coming to, I think, at some point, some convergence. We're not there yet, but I think we're getting there.
Yeah, I agree. And that's very hopeful.
Yeah, and it's great. And like you say, I know some of those Italian research teams, and like I say, the Indian teams are producing some really, really classic stuff. They've got population, they've got the research there, they've got the investment. Some really interesting stuff. And I'm just going, oh, just more, give me it more.
Yes, it's partly time, isn't it? Yeah. And of course, now with COVID, I'm trying to work out how to put everything online as much as possible, because an hour-long face-to-face assessment is not something we can do just now. You all get a vaccine. How to package this so that you can usefully assess what you need to assess face-to-face in a small amount of time and do the rest online. And there are ways, again, Italian group, Els Autobus has got a nice tool that's online.
That's right. Yes. Yeah. We're doing several what they're called language versions of Gordon's Insight questionnaire. That's coming on stream. So I know we've got a German translation happening right now. So there's all these, trying to get them online, trying to get that information out there. If part of this series is that as well, I think.
Mm-hmm.
But yeah, excellent. Look, Cathy, I've taken up a lot of your time. I'm going to, and I could chat for hours. I think in terms of research methodologies, instruments, and what I could go on for years. Right? I'm not too sure everyone else will be interested in, but
oh well, I'd share your interest, so anytime.
Yeah, we could talk much more about ICA. I'll definitely get in touch with you about.
Oh yeah, that would be great.
I think that's really good. And yeah, the strength and difficulties questionnaire. Yeah, it's funny how that's suddenly popping up into my consciousness now, and I'm looking at that, and obviously the quality of life questionnaire is fairly standard now, but out of looking, doing quite a comprehensive review, it's like, yeah, that's the one I'm gonna have to use. I think that's the one that's gonna tell me what I need. So, but there are other instruments out there, and we somehow, as a team of researchers supporting children with CVI, we need to somehow maybe this might be a great PhD project for someone. Get a really nice, here are some instruments that are being used, and look at that and see,
That's a very good idea, yeah. There's some very nice work done in London by Jugnu Ranghi's group with their functional vision questionnaire. And vision-related quality of life, and I'd love to see how that relates, because that was developed from children with visual impairment based on low acuity, some of whom will have CVI, but some not. So see how that, I suspect there'll be a lot of shared, a lot of overlap with, and that would be a useful tool for children with CVI, but that needs working on, I think, and it's beautifully designed, so will be very useful.
National treasure. As we all are, I think. So excellent. Yeah, great. So I'll be in touch, Cathy, and as soon as those papers are out, I'm going to do a follow-up interview with you and go, okay, so you say...
I'll let you know, and I'll have slides with the graphs.
Yeah, with the graphs there.
I'll let you know as soon as possible. We'll send it to you if that's the sensible thing to do.
Yeah, that'd be brilliant. And we can have another conversation once it's out. But excellent, Cathy, and thank you so much for coming on. And
thank you. I'm honoured to be asked.
And I'm just, as you know, I just can't wait. And it's important. The work you do, Cathy, is important. Both obviously in clinic, but this academic research is important. We need evidence, and we need it done properly, correctly, right. You know, we need it done in the right way. And thank you for that, Cathy. Thank you
Well,
so much.
thank you. Can I just to honour NIHR, can I show my final slide?
Yeah, of course. Yes, yes, yes. Like I say, I always thank my funders. Thank you,
Yeah.
Scottish Government. Thank you.
Oh, there we go. Oh, it's all got. Anyway, thank you, NIHR. And this is our views, not theirs.
Absolutely. Yeah, no problem.
Oh,
And
I've lost it now.
have you lost
Where
it?
are you? There you are. Hello. Anyway, thank you very much.
All right, excellent. Take care, Cathy, and I'll speak to you very soon.
And you. Thank you. Bye-bye.